Hello and welcome to our podcast, Hello Apollo, our weekly podcast on health, wellness, and well being. I'm your host, Dr. Karan Thakur. Each week, we take a health issue and discuss it in detail with our experts from the field to bring to you credible information to keep you healthy and safe. This week is no different, and I will be discussing newer modalities to take care of heart disease. And I have with me, and I'm delighted that he could join us, Dr. Ranjan Modi, Senior Consultant Cardiology, who has joined us here. Dr. Modi, welcome to the podcast.
Hi, good afternoon, Dr. Karan. Thank you so much for this opportunity for me to be able to speak.
Thanks for joining in and sparing your time. For those, the uninitiated, Dr. Ranjan Modi is not amongst, he's amongst the leaders, not just in cardiology, but in also newer interventions. And he's brought some path-breaking technologies and interventions to patients at Indraprastha Apollo Hospitals. So I'm delighted to have this conversation with him. So, Dr. Ranjan, let's start with a more broader question that we're going to discuss around the newer interventions and more specifically Tavi and Tavr. Now, for the uninitiated listener who might be sort of figuring this out, what is Tavi, what is Tavr, and where are they used?
So, people need to understand Tavi or Tavr is basically transcatheter aortic valve implantation or transcatheter aortic valve replacement. Now, there is an aortic valve which is present in the heart. This aortic valve is like a door which gives way for the blood to go from the heart to the various vessels and get supplied to all the organs in the body.
Right.
Now, when the door gets stenosed or narrowed, we call this as aortic stenosis. This aortic stenosis, what it results in is decreased blood flow to all the organs, which can lead to all these organs shutting down because the entire food, the entire oxygen is carried by blood to these respective organs.
Right.
Now, this aortic valve needs to get replaced because as the blood supply does not improve, patients will have various medical comorbidities. This aortic valve can be replaced or corrected either by surgical way or the other way being a minimally invasive procedure, which we call as Tavr. So Tavr is basically replacement of this aortic valve, correction of this aortic stenosis by a minimally invasive method.
Right. So why does this stenosis happen? Why does this condition emerge?
Most of the times, this stenosis takes place because of increasing age. As you grow older, there are a lot of calcium deposits which takes place in these aortic valves, and this calcium deposits can narrow down this opening. Now, with the Tavr procedure, the best part becomes is as it is not an open heart surgery, the various complications related to a Tavr are much lesser than open heart surgery.
Right. So basically what I'm hearing is that this is sort of progressive. So as you age, you are likely to develop this condition. And because of that, you have to undergo a corrective procedure. And this is better than traditional open heart procedures. Now, what are some of the signs and symptoms that you find people coming to your clinic displaying, which would make you start thinking about this procedure?
So most of the patients which present to us with aortic stenosis have generally angina, which means chest pain, right, either on walking or at rest. They can have dyspnea or breathlessness, either on exertion or even at rest. And they can even result in syncope or what we call as giddiness or vertigos. Because when the blood supply does not reach the brain is not able to give you that postural correction, and thus the patient can come with syncope and vertigo. So if the patient has any of these symptoms, the patient needs to undergo basic investigations like an ECG and an echocardiography. The echocardiography and ECG help us find out if that aortic valve is narrowed and what is the opening of that aortic valve at present. And echocardiography obviously is the gold standard method to confirm an aortic stenosis.
Right. So you'll do your workup and then you'll come to a conclusion on how best to proceed.
Yes.
And, I'm asking this question because there's a lot of interest around this. Because we are seeing some exit waves of COVID now, and hopefully that's the end of it. A lot of people have questions around COVID and its impact on heart health. Does COVID have any impact on stenosis?
As of the literature which we have now, we do not find any direct correlation between aortic stenosis and COVID. The aortic valve seems to not be affected by this infection. This aortic stenosis is basically more related to increasing age of these patients.
Right. So one has to keep that in mind as being the cause of it. And obviously, if you do have such symptoms, please do consult a specialist like Dr. Ranjan to basically assess what is going wrong and how best to fix it. Now, if I were to do a little bit of a versus, you've mentioned Tavi and Tavr, and you've mentioned open heart surgery, traditional methods. What are the pros and cons both ways?
So, in an open heart surgery, yes, obviously your sternum is open. That means your chest is open and the valve is replaced. And that requires a longer stay in the hospital. It takes about a week, 10 days for the patient to be completely rehabilitated from the hospital. The total rehabilitation course might sometimes even go up to 15 days to 1 month for the patient to be able to get back on his feet and get back to his normal quality of life. In the case of Tavi and Tavr, the most important part, or let's say the most beneficial part, is that because it's a minimally invasive procedure, the time of procedure is low, the hospital stay is very decreased. So if you take up a patient for a Tavr or a Tavi, the patient can get out of the hospital within 3 to 4 days, and he can start resuming his normal routine activities within about another 2 to 3 days. So within a week, a patient who had severe debilitating symptoms, like could not walk and could not do his routine activities, can get back to his feet and do everything which he used to do previously within a week. And moreover than that, the various complications which are associated with an open heart surgery are also avoided with a minimally invasive procedure.
Right. So the clear advantages there. Dr. Ranjan, if you could just talk to me about, say, what does this entail? Because a lot of our listeners may be confused about what exactly would you do if you said that, you need to undergo a Tavi or a Tavr.
So as we spoke previously, we need to first diagnose if the patient has an aortic stenosis. So that is done by a non-invasive investigations like an ECG and echo. Once the echo and ECG have confirmed that the patient has an aortic stenosis, then the patient needs to undergo multiple pre-op assessments of how good a Tavr would be for him or her. These pre-op assessments include CT aortogram, which means we look at the entire aorta from the valve all the way down into the legs. So the entire route through which we are going to put the valve is evaluated. We look at various areas where the calcium, what is the diameter of the vessels. So there are multiple things which are evaluated. Plus, then there is always a discussion with the cardiac team, which this cardiac team always includes a cardiologist, a cardiac surgeon, a cardiac anesthetist. So we all sit down and we assess how good or bad would this procedure be. Once a decision has been taken that yes, this procedure would be beneficial and provide huge benefits to the patient, then the procedure is planned and then the patient can undergo procedure.
Right. And during the procedure, you're actually replacing a tissue, which is the valve, with something which is artificial. So what is it that you're replacing it with?
So what we use in Tavi or Tavr right now are known as bioprosthetic valves, which are kind of similar to what I used in open heart surgeries, valve replacement as well. So these are either bovine or porcine valves, which are crumpled onto a delivery system, which is basically either a balloon or a self-expandable valve, which either can be used, and that is placed at the aortic valve position, and it is expanded or it is self-expanded through the delivery system, and it is left in place there. So the native valve is just crushed between the aorta and the new aortic valve. So we do not take everything out. We just make sure that the diameter of the vessel, which was narrowed, the aortic valve which was narrowed, that opening is now expanded back, so that the amount of flow which was happening through the blood vessel is maintained.
Right. And you spoke about how quickly they could go back to work, but or go back to activity rather. So what happens after the procedure is successfully done? How long do you stay in the hospital?
So ideally, how the procedure is done from the leg. Okay. We go from the leg, we go all the way into the aortic valve. The most of the times our patients are always minimally sedated. That means they are not put on a ventilator. There is no general anesthesia which is used. There is something what we call as conscious sedation, which means that immediately after the procedure they are woken up.
Okay.
They are shifted to the ICU, where they stay for about 2 days. They go to the room where they stay for another 1 to 2 days. So by the 4th day from the procedure, the patient is going back home, and in about another 2 days he's going back to his routine activities.
Wow. So I mean that sounds astounding. One, you're not going to be fully sedated while the procedure goes on, and therefore the recovery is better, and you actually go back to a regular routine pretty much within a couple of days, give or take.
Exactly.
Right. So this sounds too good to be true. Are there any downsides to these procedures?
See, most of our patients who undergo Tavi is not because that the procedure is short. Most of our patients which come to us for Tavi or Tavr have always come to us with at a pretty old age, as we said, because these aortic valves get stenosed at the age is one of the most important factors. So a lot of these patients have either undergone already a valve replacement or an open heart surgery, like a CABG. So they've already had a surgery where the chest has been opened. Now, making them undergo, the biggest benefit of this Tavr or Tavi is that we do not have to repeat an open heart surgery for these patients, because a second open heart surgery for any procedure always carries a very high risk.
Right.
So the biggest beneficial point of Tavr is for those patients who have already undergone any open heart surgery for any procedure, including the heart, the lungs, any glands, anything in which the heart has been opened. For them, Tavi becomes the biggest boon, because the risks of a second open heart procedure are always high. So for them, a minimally invasive procedure is able to provide them the same amount of benefits, or rather better benefits than a second open heart procedure. Plus, obviously, the lesser stay in the hospital and the sedation, what we spoke about.
Right.
The downsides of this procedure, we always say every procedure has its own risk and complications. In case of Tavr or Tavis, always, because we are creating a route all the way from the leg all the way into the heart, there can always be small injuries to the vessels in the legs. There can be injuries to the aorta through which we reach. So these are known complications which have their own management, which has already been planned beforehand to them. So overall, yes, it carries the risks, but the risks are far lower than the benefits they provide.
Right. So there is a sort of a limiting of the downsides, is from what I hear, especially what the upside has to offer.
Exactly.
And are these procedures not recommended for some specific type of people?
See, in patients in which we do not have an approach reaching to the aortic valve, like they have very small arteries, they have severely calcified arteries. In those patients, yes, the risk of doing these procedures are high, because the valve itself has a particular size, and we need a particular amount of size of the vessel to be able to reach the aortic valve. In these patients, obviously, yes, the risk becomes higher. So a lot of times we do not recommend them. It's also in patients who are young. we would obviously not recommend Tavrs or Tavis, because in such patients, obviously, open heart surgery is useful, because open heart surgeries can help these patients cover a particular amount of time, and once the open heart surgery valves are diseased, we can always replace pen with Tavrs. So at open Tavis or Tavis at 30s and 40s are not recommended, because they're too young patients, and we still have data for Tavr or Tavis only for the last 10 to 15 years, where we have seen huge benefits of Tavr or Tavis, but we do not have data like open heart surgeries for the last 50 years. So we always recommend younger patients to undergo open heart surgeries and replacement of valves, but older patients who cannot undergo surgeries, who have no other second options, for them Tavr and Tavis are the best.
Right. And you spoke about data, so I just wanted to ask you to throw some more light on it. What has been the outcomes, the success rates that you have seen in the past 10, 15 years and in your own practice?
The data what we have at Tavi is about 10 to 12 years old now, and they have shown to be very, very good. The benefits of these valves have been great. These valves have been able to last for about 10 to 12 years easily, and that's the best part. So because we're using the same bioprosthetic valve, as kind of similar bioprosthetic valve as we do in open heart surgeries, the longevity of the valves is good. And because it's a minimally invasive procedure, all the risk and the complications which are related to open heart surgeries can be avoided. So it's one of the biggest boon to interventional cardiology in the last so many years.
Right. So it is a boon, as you said, and there's some good data to back it. If somebody were to be listening and wanting to take this decision, what is it that you would tell to them in terms of or refer to a success story that you may have in your practice about the impact this can make, the positive impact on your life and also quality of life rather?
So we recently did a case. This was 82-year-old male, and he had undergone bypass about 10 years back. His grafts were working fine, and obviously we knew that at this age doing a repeat CA open heart surgery would be very difficult for him, and he had aortic stenosis. And the patient got admitted, everything went smoothly. Within 5 days he was out, he went home. And the best part was, after about 15 days he called us from Greece, and he was taking a walk. And he called us and said that, "Sir, I can walk right now, and I could not even go to the toilet, and I'm so happy. I'm at my feet with my grandchildren, and we're taking a walk all around Greece, and I'm just delighted and so happy to be like this." So these such patients just make your day. They just make sure that zeal of trying to make patients better, the zeal of cardiology always stays there. And it's such a beautiful thing to know that somebody who could not just walk even 10 meters is now going about 1.5 kilometers and walking and having fun of his life at this age.
What a fantastic story, and God bless this patient. I hope they have many more years with their family and their grandchildren. And I know, Dr. Ranjan, you are a bit of a futurist. You always are looking into the horizon of what's happening next. How do you see cardiac surgery interventions evolving? What are the new things on the horizon that patients and normal people should be looking at?
So I think where we are leading as cardiologists and cardiac surgeons is always minimally invasive now. Right. We are leading to more of a robotic assisted, more precise, less complications surgeries and procedures, where the patient can get back to his feet and get back to his normal routine as quickly as possible, where the rehabilitation of such patients is as shorter duration as possible. So I think the next few years, even in cardiac surgery, is going to turn into robotic surgeries and minimally invasive surgeries, where you do not need to open up your chest. We can do just a pinhole. We can do the entire procedure, and you can be out, up and about within about 2 to 3 days. I think that's what's going to happen in the next few years.
Fascinating, and it's always fascinating talking to you, Dr. Ranjan. I have to draw this conversation to a close, but it was wonderful to have you speak with us. And I hope to bring you back soon so that we can discuss the other frontiers of what you are doing in terms of cutting edge cardiology at Indraprastha Apollo Hospitals.
Sure, Dr. Karan. That was great to speak to you. Thank you so much.
Right. So that was Dr. Ranjan Modi, and as he said, these procedures are life-changing, and he gave a very good example. And also, if you are eligible or you have more questions around this procedure or anything else, do reach out to us at Indraprastha Apollo Hospitals. Our board lines are open for you to make that call and set up some time with Dr. Modi to discuss your case or of that of a loved one. Please also reach out to us on our digital platforms or DM us, and we'd be happy to connect you with Dr. Modi. And do encourage your friends and family to listen to our podcast. We are available on all leading platforms because remember, good health is for everyone. So do join us next week when we will have another specialist from Indraprastha Apollo Hospitals discussing another health issue of importance. So till that next episode, stay happy and healthy. Thank you.